Good afternoon on this wet and rainy day from Nicosia Rick Classic, and we're going to be discussing bipolar disorder today with my eminent psychiatrist, Dr. George Mikellides. I say my because you come often, and I'm pleased to have you here on the program. So a very warm welcome. If you have any comments or questions, please do put them forward, and we'll be happy to answer them. So we've just heard Maria Callas with Visite Artem, the music of Puccini. A reminder, you're tuned into Rick Classic 88.2. We're coming to you live from the 4th Radio channel. We're also live on Facebook at the moment, and that's with my very special guest, the eminent psychiatrist, Dr. George Mikellides, also the developer of Cyprus RTMS, transcranial magnetic therapy. Today we're going to be discussing bipolar disorder, and thank you very much for being here in the studio once again.
Good afternoon,
Despite
Saskia, thank you for having us today here.
Very bad weather today.
Very bad weather indeed.
I'd like to begin with asking, what is bipolar disorder and how do you go about diagnosing it? I just want to clarify as well, it's also referred to as manic depression.
That's right.
Right.
That's the old term of bipolar disorder. It used to be called manic depression. We still hear this term quite often today. So basically it's a mental disorder which affects around 1% of the population. In the United States the numbers are around 3% of the population. Equally affected men and women as well. Usual onset of the age of 25, so people usually as an average will be affected by this disorder at the age of 25. It does not mean that if you're 50 or 60 you cannot get it, but most of the patients will get this disorder by that age.
Yes.
So as the term manic depression states, is or bipolar disorder, which is the new term, we have a bipolarity, we have two different areas. We have depression and we have mania or hypomania. So we all know what depression is in terms of the feelings, in terms of the symptoms. So anhedonia, lack of pleasure, lack of having satisfaction in your daily activities, for example. And when we talk about a depressive episode, we're talking about 2 weeks of these symptoms at least. So if you don't feel good for a day, that doesn't mean you're depressed.
Yes.
But if you have these persistent feelings of depression for more than 2 weeks, which we can describe in detail, then we discuss and we talk about a depressive episode. So we can mention the symptoms of depression if you like.
Yes.
So we can clarify a few things about what is depression, and then we can try to move what bipolar disorder covers.
Yes.
So obviously we have to have a low mood for at least 2 weeks. Our sleep is affected, meaning that we either sleep too much or too little. So something different than the usual.
Yes.
We also have, as I said earlier, anhedonia, so lack of interest and decrease of satisfaction of pleasure, basically. Our, let's say, appetite changes, so we can either overeat or eat less than usual. So these are called biological symptoms of depression.
Yes.
We have our interest in sex, the so-called libido, affected as well. So we don't have anymore the interest in sex and interest in activities that we used to like hobbies, going out for drinks, for coffee, for going out to restaurants, cinemas, etc. So we don't have the interest to do these things. Our motivation also changes, and also our concentration is affected, so we cannot concentrate. Our energy levels go down. So these are some symptoms of depression, as we know, and we need to have these symptoms for at least 2 weeks to talk and discuss and diagnose someone with a depressive episode. So we're in bipolar.
Yes. No, I just wanted to say that's not the mania.
No, we're just discussing about what a depressive episode is.
Right.
So, and then in bipolar disorder, there is usually we discuss about bipolar disorder type 1 and type 2. So mainly there are two types of bipolar disorder, and in bipolar type 1 we have the mania, and in bipolar type 2 we have the hypomania. The main difference between mania and hypomania is that in mania you lose the control. So that's something quite worrying. If you're not able to control yourself, where we see this in mania,
yes,
it's quite dangerous and risky.
When you say lack of control, what type of control are you referring to?
Mm-hmm. So, just to describe mania as well, what is
yes,
mania?
Yes.
Mania basically presents with symptoms such as lack of sleep. People don't sleep or sleep very little during the days. There is a pressure of speech. They speak very quickly.
Yes.
It's like someone is pushing them to talk, or they cannot be interrupted when they speak. They present with increased amount of energy. They feel sometimes that their thoughts are racing, so they are not very clear in their thinking, so they might have a lot of ideas. There's something called like flying of ideas, so
yes,
your ideas are like flying and they're so fast that you want to do 10 things at the same time. And
that feels a bit like me. Yes, okay, jokes aside, yes.
Yeah, and you might also experience symptoms of psychosis. So lose basically touch with reality.
Yes.
And some of the people experiencing a manic episode, around 20% of these people might go into presenting with psychotic symptoms, which are very similar to schizophrenia. They're so-called first-rank symptoms of Schneider, as
right,
the psychiatrists will know. And these symptoms are characteristic of schizophrenia, but they could present in the context of a manic episode, which does not mean you have schizophrenia. You might have bipolar disorder, but they're very similar to these symptoms of schizophrenia, this psychosis basically,
yes,
these psychotic symptoms. You might start thinking that you have like supernatural powers, you can fly, you can read someone else's mind, you can do things that they are out of the ordinary and out of this reality.
Yes.
And it can be dangerous, obviously. Most of the patients with a manic episode should be hospitalized, should be treated in hospital, because there is always the risk of suicide.
I was going to say, if you think you can fly and you're on a bridge,
yeah,
maybe you're going to do that.
Yeah.
How long is this episode? It was quite clear that depression, what makes it different is that it needs to be at least a 2-week episode. Yeah.
So
what about this?
So for a manic episode, usually we think about 7 days.
7 days of continuing with these.
Yeah, but if you're obviously hospitalized, right, this amount of time could be less.
Yes.
In hypomania, as I said earlier, one of the main differences between mania and hypomania is that in hypomania you will not experience psychotic symptoms. You will not lose touch with reality.
Yes.
But what it occurs is like you can feel very energetic, you can feel happy, you can feel I'm on the top of the hill, on the top of the mountain, on top of the world. But you might be able still to do your job. So you might be able to still do your job very well, because you're thinking fast, you can do your job very quickly. But on the other hand, it's very draining, right? Because your energy at some point will run out,
yes,
and you will be exhausted.
Yes.
And it can be very distressing at times as well for some people.
Are other people, when you mentioned that they will continue with their job, are other people aware that that person is not really behaving normally and that they are having an episode?
Yeah, I mean, if you really know someone, like a colleague, if you spend time with that
yes, person
in your daily routine at work,
yes,
you will notice a difference. You will notice, oh, you look very happy today. You look like, I don't know, something is going on. And you might be able to notice a difference, obviously, if someone is hypomanic. Obviously, it can get more complicated if there is also a personality which is very jubbly and happy most of the time, and you might not be able to tell the difference in some people that their personality is also very similar to a hypomanic episode. Obviously, for the clinician, for the psychiatrist who is knowing what the diagnosis is and the symptoms and how to assess the mental state, they will be able to differentiate the two.
Yes. What is the primary cause of bipolar disorder?
So as any other mental disorder, we talk about genetic factors, we talk about environmental factors, so it's multifactorial. We know also that if there's an abuse in childhood, then obviously that's a risk factor. If your dad or your mom has a history of bipolar disorder, then obviously, as we said, the genetic risk increases. So there is a high genetic load in bipolar disorder, so people can have a bipolar disorder if their dad or mom had or has a bipolar disorder, somewhere between 10 to 20% risk if someone or your parent has bipolar disorder.
You mentioned environmental factors. Are you referring to things like stress?
Exactly. So chronic stress, different factors that they can increase your stress levels in your daily activities, in your life, basically increases the risk of developing bipolar disorder. And as we say, also environmental factors are here to say that if there is an abuse in childhood, then that's an environmental factor that has an impact on your mental state, your mental health, and subsequently you might develop bipolar disorder at some later stage.
The symptoms that you actually describe don't seem that out of the ordinary, and it seems that many people could say, well, I felt very euphoric. I felt very depressed for 2 weeks. You've had a death in the family. You've moved house. You've moved country. These we all know are events which cause high stress levels. What is there that differentiates the person who just goes through this for a certain period of time? Do there have to be recurrent episodes that continue for 2 weeks over several months in order to say this is not something you don't have bipolar disorder?
Yeah. So obviously the history taking is fundamental. Yeah, you really need to do a good history taking. And for myself to diagnose someone with bipolar disorder without seeing the patient being in that state,
yes,
it's very difficult, because anyone can walk into your office, your clinic, and say, oh, doctor, I had this manic episode for like a week and I'm fine now, without you witnessing this presentation. So
and I'm wondering how much courage would somebody have to actually come in and say that?
No, people do that.
They do come in.
People do that.
All right.
So I think what's important here it's the right diagnosis, the right treatment, and taking a good history, not just from the patient, but if you have the ability to take the history from like collateral history, like from family, parents, siblings, friends, etc. So it's like putting the pieces of the puzzle together and coming out with the right diagnosis, because the right diagnosis will give you the right treatment as well. And obviously you don't want to be on a medication which has side effects if you don't actually have the diagnosis of bipolar disorder.
Is there anything specific which triggers it?
So high levels of stress, I was saying. So a lot of people these days, they might be juggling between different things, like 2-3 jobs, highly demanding family, many children, like you're up and down all day basically. So all the stress levels are high, then that's an impact on your mental state, and eventually that's a risk factor. That's how we see it.
Stress is something that we've spoken about on other programs. Just as a general factor, it seems to be something one has to avoid at all levels.
Exactly.
It
destroys the brain. It destroys the cells. It destroys the neurons. So obviously we do know that stress is related with organic physical health problems as well as mental disorders. So we can see Alzheimer's, we can see cardiovascular problems, we can see diabetes, cancer, your immune system goes down. All these are kind of like interlinked together. So it's very important, it's paramount to get your stress levels down to a certain acceptable level of day-to-day functioning, basically.
Do you think that the work environment and people in management levels are sufficiently aware of what the damage is of stress to their employees?
I don't think so. And that's very scary as well.
Yes.
And it's not just the stigma of mental disorders, but it's also knowing how to recognize the kind of difficulties like your employee might be facing and trying to help them through and provide them with the right support. So obviously the employer or the manager or whoever is there to kind of like monitor the work of an employee, they should be able to spot changes in someone's life. As you have said earlier, it could be bereavement. So, I mean, we all experience bereavement at some point in our lives because we are all familiar with death at some point of our lives. But there are differences.
In Cyprus, it's quite tough. You've got one day to get over it.
Yeah, it's just not just tough, but it's just, I don't know what words you could use to describe that, but it's very difficult. It's very difficult for the person you cannot deal within a day.
No.
And if you don't feel too good about it, you should always get the right support. And we all know that there is a bereavement reaction, and in psychiatry there is something else we call abnormal bereavement reaction.
Yes.
So, and there are differences, and one of the differences are the duration. And there's not the right amount of time that you can bereave your loved one or you can grieve your loved one. But some people talk about 6 months, for example, just as a rule of thumb. Maybe they would say 6 months should be enough to be able to deal with the most difficult part of the bereavement. But on the other hand, if you're experiencing, for example, suicidal ideation, you want to die, so that's not part of a normal bereavement reaction. That could be part of an abnormal bereavement reaction. That could be part of depression. So that's a huge difference if you have suicidal thoughts, for example.
How much of a role does alcohol play in bipolar disorder?
So a lot of the time, as we see in mental disorders, patients, they might try to self-medicate. So trying to self-medicate with either alcohol or drugs, either when you're in depression to lift yourself up, or either when you're very hyperactive to get yourself down. So people might use alcohol to cope with an episode. So it is quite common to see a comorbidity, as we call it, which is the use of drugs or alcohol within the bipolar disorder. And it's very important to know as well for psychiatrists or for doctors and for any layperson who is interested in mental health, that people that use cocaine every day, they can present with hypomania. That's not in the context of a bipolar disorder. That's in the context of using stimulants like cocaine or amphetamines, for example. So doctors, psychiatrists should be able to differentiate and say this is due to cocaine. You're high as a kite because you're using cocaine, and you're not high as a kite because you have a bipolar disorder or you're going through a manic episode, for example.
How important is the family in diagnosis? And you mentioned earlier that patients actually come to you and say that they've had some kind of an episode. I had a reader previously saying to me that it was very difficult for him, for example, to get his wife to admit that she had a problem.
Yeah, so it is quite difficult, and the truth is that people are affected with bipolar disorder from all different kind of occupations. So I remember when I was in London working, we admitted a psychiatrist on the ward with bipolar disorder. We have admitted a psychologist on the ward with bipolar disorder when they were going through a manic episode and they were doing things out of character. So people, they might do things like even stripping themselves in the public, walking naked in the street, looking for sex everywhere, doing things that they can put themselves at risk. So if they don't get the right treatment at the right time, so people are very vulnerable. And obviously family will be able to spot the difference. They will be able to spot changes in someone's behavior, especially when someone is going through mania. I mean, anyone could tell that something is not right.
Yes. How would you be able to treat the person if they don't want treatment or they don't acknowledge that there's a problem?
So in each country around the world there is the Mental Health Act. So as in Cyprus we have the law, the psychiatry law for mental health. So if they impose a risk to themselves or others, they can be sectioned and can be admitted involuntarily on a mental health ward and receive treatment against their will. So that's an option that we do have in Cyprus, as it's also available, for example, in the UK and in most countries around the world.
What happens to untreated bipolar disorder?
So the literature suggests that if a manic episode, for example, left untreated, usually goes between 3 to 6 months. So it can wear off on its own, even if they don't get treatment. But it can take up to 6 months of going through that phase. Obviously, going through a manic episode lasting 6 months, it will be a huge impact on someone's life, and they could go through a lot of high-risk behaviors, and they could, God knows that they could end up dead if they don't get the right treatment. But obviously, if, let's say, they don't get the right treatment and they manage to survive through a manic episode, that's in a way an insult to the brain. So even if someone goes through depression untreated, or a manic episode which is left untreated, then your functionality might not be able to go back to where it was before. You might become chronically ill, let's say.
So it could have lasting damage.
Exactly.
Does it get worse?
With time or with the same person? Sometimes it can get worse. Sometimes if people don't get the right treatment at the right time, an episode can last longer. So it could be the first episode lasting 2 weeks, maybe the second episode could last longer. But I would say you cannot judge that, and you cannot generalize that, and it's based on case-by-case individual patient, basically. So it could be, if someone gets the right treatment at the right time, does not mean that the next episode will be worse than the previous, but sometimes we do see that as well.
What about the actual treatment? Is it done with a combination of medication and psychoanalysis?
Yeah, so obviously if you're in a manic episode, you cannot do a psychoanalysis to a patient, or you cannot do psychotherapy, because they're not anywhere in that state of mind to be able to follow therapy. But obviously what's very important in bipolar disorder is if you're going, for example, through a manic episode or a depressive episode, you should get the medical treatment, which meaning usually is medication, or it's 99% of the time is medication. So usually we use a combination of treatment. The usual treatment is an antipsychotic with combined sometimes with a mood stabilizer, which is also called antiepileptic, because it's also a drug which is used for epilepsy, for example.
Yes.
Obviously, if you're going through a depressive episode, you should be getting an antidepressant. And you should be careful as a clinician when you're prescribing an antidepressant to a patient with bipolar disorder, because they can go again to a manic or a hypomanic phase. And as well as I've been using transcranial magnetic stimulation.
I was going to ask, does that help?
Yeah, it can be used for the depressive episode as well, either with medications and antidepressant or without an antidepressant. And there is off-license treatment as well that can be used for people in a hypomanic phase to calm them down by providing inhibition to the right part of the brain.
I would also like to touch on borderline personality disorder and the difference of that disorder to bipolar. Do the symptoms overlap?
There are some similarities, and there is a huge discussion around this area, especially when it's to think about what's happening in the United States, for example. So in borderline personality disorder, we see childhood abuse as well. It could be sexual, it could be physical, it could be emotional abuse. And people will experience mood swings. So people will experience, let's say that this moment in time, I'm feeling quite low, sad, and within 2 hours, I'm quite happier and energetic. So you get these mood swings, but usually as we are within minutes sometimes or within hours, where in bipolar disorder we see this within days or weeks. So
everything is contracted.
Exactly. The duration is different. In borderline personality, we do see people having different symptoms as well, which we don't see in bipolar disorder. For example, feelings of emptiness, feelings that we're not good enough, and obviously if we're not good enough, then that's a thing that we have since our childhood, the way that people actually treated us, and people meaning school, teachers.
Is that inadequacy of themselves that you're referring to?
So basically, one of it's not just inadequacy; it's just maltreated as a child by a parent or a teacher or someone in your school. So there is the abuse there as a child in childhood, usually much more prominent than we see in bipolar disorder. And their own narrative of their own life is very broken down. It's kind of like some of the memories could be suppressed or repressed. What we tend to see in people with borderline personality disorder, we see this in their relationships. They don't keep relationships for long, so they can have like small relationships like for a few weeks, a few months, unless their partner is able to tolerate their kind of like capricious behavior, let's say.
Yes.
Because they have these behaviors that in a way unconsciously they provoke the other person to be maltreated by them, which is not very nice to say.
No.
But this is, if you go back to psychoanalysis and think about how things work and how we behave and how we express our thoughts and feelings, we tend to see that people with borderline personality disorder, they have these temper tantrums without reasons, with very small things. They have these self-harming behaviors like cutting themselves or burning cigarettes or punching themselves on the stomach, on the head. I was wondering the other day how someone punches themselves on the head and how they could all do this on themselves. So we tend to see this self-harming.
Is this to just draw attention to themselves?
No, sometimes yes, sometimes no. Sometimes it's because they don't have a good respect for themselves. So they have to, in a way, they have to show to themselves that they do not deserve anything.
Do you find that this happens to children who are alone, or are there cases where there are families with many children and only one presents, but they've all had the same upbringing?
Yeah, I think it's, as we said earlier, it's a combination of factors. It's not just one thing. We tend to see the genes. So siblings don't have the exact same DNA, so they share different genes,
yes,
but they don't have exactly the same DNA. And the upbringing of someone within the same family is not the same, even if you live in the same house. Because sometimes we tend to see like the first child gets, for example, more attention, the second child will be a bit more neglected, the third child will get again more attention, maybe the first child will get the physical abuse, will get all the physical abuse, the second, third might not get the same physical abuse. So as you can see, in a family, all children are not treated the same.
It seems as if you're saying that the responsibility for this disorder lies heavily with the parents.
That's right. Not just the family, but obviously the
that
school.
Seems quite a burden for
and
a family member to have to bear.
and it's hard to say, you cannot pinpoint and say, it's the mother's fault, it's the father's fault, it's someone's fault in regards to developing a mental disorder or borderline personality disorder.
Especially if you say that it comes, later in age.
No, borderline personality disorder usually comes within the early development of someone's personality, so in the early 20s. Even some people, they say, oh, it might be presenting even earlier before you enter adulthood, but there is a debate in the academia in terms of the right onset of personality disorder, but usually mostly accepted that in the early adulthood people will present with symptoms or traits of personality disorder. And another thing which is very important is what we tend to see, especially in this is rumors, I would say, but I think behind some rumors there's always something true. And I think what we tend to see, for example, like in United States, the percentage of bipolar disorder is 3%, where in the rest of the world it could be around 1%. So it's a higher, let's say, prevalence of bipolar disorder in United States. In borderline personality disorder, there is not a single medication, a psychotropic medication, which is licensed for the treatment of borderline personality disorder. So where in bipolar disorder, there are a lot of medications which are licensed for treating bipolar disorder. But as we know, because even as you have mentioned, there are similarities between the two, like the mood swings, the changes in mood. We can see that mood stabilizers or antipsychotics can be of some help in people with borderline personality disorder. So these medications are used, let's say, off license, without being licensed for the specific disorder.
Yes.
So especially with insurances, let's say that an insurance, like in the United States, will cover you to take a single medication if you have bipolar disorder, and this specific medication is licensed for the disorder you've been diagnosed. But if I diagnose you with borderline personality disorder, you're not entitled to take that medication, which could be of some help to you. So if I diagnose you with bipolar disorder, then you will be entitled. So I will say that perhaps in the United States, there is some misdiagnosing of borderline personality disorder with bipolar disorder, sometimes maybe done on purpose, so the person would be able to get the medication which is licensed for something else and could be beneficial to you in a different way. But on the other hand as well, which is very important, and we see this not just in the United States, we see this in UK, especially with private practices, is no one really likes the term of personality disorder. Because people tend to feel that something with their character, something within themselves, something is wrong with their own personality. Where if you have bipolar disorder, it's nothing to do with you, it's just an illness like any other.
Right.
So it's much more, let's say, funky for some people to be diagnosed with bipolar disorder. They will be much happier being diagnosed with bipolar disorder rather with being diagnosed with borderline personality disorder. And there are differences in terms of the treatment here, because as you have mentioned earlier about psychotherapy, the psychotherapy for someone with a personality disorder is completely different to someone having bipolar disorder.
What would the treatment be? And again, my question is how to get somebody to admit and to acknowledge, and especially with the symptoms that you've described, someone to admit that there's something wrong with them and that their relationships are dysfunctional, and not only with maybe 2 or 3 people, but with all the people at some stage. How do you get them? How do you get to treat them?
So people with personality disorder, which it's an umbrella for different types of personality disorders. It's not just borderline personality. We have antisocial personality, paranoid personality disorder, we have schizoid, we have schizotypal personality. These are different types of personality disorders. So
that's very good that you mentioned that, because we've only touched on one. So
there is histrionic personality disorder, there is an ancastic personality disorder, there is anxious avoidant personality disorder. There are different types of personality disorder.
Right.
So, and some of these personality disorders, they might never get to see a psychiatrist, or they might never go to see a specialist. Unless you have a difficulty, let's say depression, anxiety, etc. But in borderline personality disorder, they tend to come to our side, let's say, in a way that they might present with chronic suicidal thoughts, overdosing, taking like 5 tablets to kill themselves. And then when you ask them, why did you take only 5 if you actually wanted to kill yourself? And say,
Yes.
oh, I couldn't bother to take more, or I didn't have more at home, or some kind of excuses in that we have. So they will come to accident emergency because they have taken an overdose, for example. So they will see the accident emergency doctor, and then they will be referred to a psychiatrist. So they will get into the system, let's say, if they have a borderline personality disorder.
Yes.
But then again, they will also get to see a psychiatrist because the chronic symptoms, such as chronic suicidal thoughts, temper tantrums, getting into troubles with everyone, basically, the tension, they feel intense tension, basically. They're seeking for some help because it's very distressing. So they will, or through their families, they will get to see a specialist at some point. Usually with borderline personality disorders, most of them, they will get to see a psychiatrist quite soon.
Can you tell us about the links between BPD and violence or borderline rage?
Mm-hmm. So obviously we tend to see in borderline personality disorder people having problems with the law in terms of becoming violent towards their partners, towards themselves, towards property. So they tend to, let's say, abuse alcohol and drugs. So they might have been arrested because they were drunk and disorderly, let's say, in the middle of the night, or because they were shouting and screaming and causing some issues around their neighborhoods. We don't, in borderline personality disorder, we don't tend to see big crimes, but obviously we tend to see small crimes, usually domestic attacks and domestic violence between partners.
Living with someone who has BPD must be very challenging. Can you also tell us about splitting?
Yeah, so splitting is a defense mechanism, as it's been described. A defense mechanism is an unconscious mechanism that we're not aware of it, and basically its function is to kind of like save our ego in some ways. Not ego as being selfish, but ego as the moderator between superego and need, if we go back to the psychoanalysis or the Freudian understanding of someone's behavior. So splitting usually, as we said, is an immature defense mechanism, and the person will see things as black or white. So you could be the best teacher in the world. You are so good in your work, and this could last for a few days until you tell me I haven't done my homework, and then you become the worst teacher in the world. There's no gray zone.
There's a sort of...
And then next month, you're the worst partner in the world. So there's nothing gray. There is no gray zone, and people find it hard to understand the world that is not just black or white, but there's so many colors in between.
In America, you said, and studies show that the prevalence seems to be higher. Do we have any statistics or figures for Cyprus?
We don't have any statistics for most things in Cyprus,
No.
as you know, Saskia. But usually we tend to say that it's around 1% as the rest of the European population, or the most of the world, let's say. It's around 1% for bipolar disorder. Or are you referring to borderline personality?
Both.
Okay. So bipolar, as we said, is around 1%. When we go into personality disorders in general...
Yes, because you've highlighted that there are quite a few.
In the old days, they used to think that 1 in 5 people have a diagnosis of personality disorder.
Oh, that's quite high.
That's quite high.
Yes.
But in these days, we think it's around 5%. So we think it's around 1 in 20 people, not 1 in 5.
Right. I'm just wondering what's going to happen now with the advent of YESI, and how it's going to affect somebody who's arriving at the A&E department, they've overdosed, and whether they're actually really going to get the help that's needed, because this is something that needs time.
So as my understanding is at the moment, some of the mental health hospital, Athalassa Hospital, will continue to be under the governmental or the Ministry of Health in terms of monitoring instead of the finances, etc. So if someone needs to be sectioned and be admitted involuntarily on the mental health ward in Athalassa Hospital, that's not really much of YESI, but it's still part of the Ministry of Health. And obviously, if you are not at high risk to yourself or others, then you have the option to be discharged home by the psychiatrist if they find you healthy enough to go home, and then you can seek either private help or through YESI, I suppose.
What would you have as final words of advice, either for people who believe that they're suffering from an episode, or from families who believe that their children, spouses, or anybody in the family is not?
In a way that families are facing different mental disorders in family, and what's very important here is to try and support their family members to seek help at the right time. They don't have to wait until things get really, really, really bad, because when things get really, really bad, it will take much more time to get back to where they were before relapsing in their mental state. So prevention is obviously number one, but apart from prevention, is getting treatment at the right time is quite essential as well. We still have the stigma in Cyprus.
I was going to just touch on that before you left. How are we going to dissipate the stigma, not of bipolar only, of personality, but any sort of mental illness?
So education. Psychoeducation is very important, not just in Cyprus, but anywhere around the world. And psychoeducation, not just to their families, but to the patient as well. What we tend to help the patient with is providing psychoeducation and understanding like triggers, signs of relapse, early signs of relapse.
Yes.
If you're able to identify these small signs before you go into full-blown relapse, then your treatment can be adjusted accordingly, get the right treatment at the right time so you don't go into a full relapse. Going into full relapse with a manic episode or a depressive episode, that could be at least a month away from your family, away from work, away from your social interactions. It could be longer.
Do you think that there's enough education in high school, at a high school level?
Probably not. And
what do you think could be done about that? Is there any interest from the education, the Cyprus Education Department, to be aware of this, to address these issues, for teachers, possibly to undergo a course so that they can actually be aware of children who are misbehaving? You know, we see that children, they're called misbehaving, looking for attention. I always would like to go a little bit further into the case and say, why is this happening?
So what we tend to see usually is managed by the child psychiatry services in people in school. So under the age of 17, usually seen by child psychiatrists.
Yes.
And I'm aware that child psychiatrists within the public health sector, they do visits when required to assess someone in school, or they liaise with the school in regards to people having, for example, ADHD or autism or behavioral issues. But I think there's always more to be done, and I'm not quite sure in terms of the Ministry of Education and how much work they're doing in regards to educating the teachers.
Yes.
And not just the teachers, but the students as well.
They spend 8 hours of their day there.
I know, and and it's quite common to have someone with a mental disorder. There will be always students with mental disorders in schools, and a lot of the time teachers should be able to recognize and help them accordingly.
I'm not even thinking of a mental disorder, Dr. Mikellides. I'm thinking from the stress aspect that you spoke of earlier, because it seems that stress is the primary way that we see all these other disorders manifesting themselves.
I'm aware that there are also educational psychologists that they provide supports in different schools when needed, and I did liaise with educational psychologists on a few occasions in regards to different students that they were either experiencing difficulties with their concentration or with their behaviors. And what tend to be quite recognizable is when someone gets into fights, often they create trouble, and obviously the teachers needs to do something about it. That is when they will say, oh, you need to see a psychiatrist now because we will not tolerate anymore this behavior in our school.
Yes.
So things have to be quite at high level of difficulties to seek help through a psychiatrist. And
do you think that's a little late?
It could be late, and what we tend to see as well is a child's behavior is a reflection of what's going on back home. And you cannot just treat that person, because you need to treat the whole family. Parents are the root of the problem in someone's behavior in terms of a child's behavior.
Right.
So what we tend to see is like...
I think some parents must be crying now if they're hearing this.
But that's the truth. You know, I cannot just hide behind my finger and say this is not the case and we have a difficult child. Obviously, there are cases that there are difficult children, and there are difficult cases to be managed, and especially if it's to do with autism. Because if you have a behavior, if you have a pervasive developmental disorder, then that's something else there. Then this is not just a reflection of the parents, but it's part of the pervasive developmental disorder. So I'm just giving now a justification, which is something different. But if it's to do with like an oppositional defiant disorder, like a difficult child in a way that they oppose to school, they oppose to family, or we have contact disorder. We have children, they're kind of like it's the first steps of becoming an antisocial. 1/3 of the contact disorder children will go on to developing an antisocial personality disorder. So they will create crimes, they will get into criminal activity from early age, from their teenage years. So these people have difficult times at home. They witness, let's say, parents fighting, abusing each other, getting abused by parents, becoming a bully or being bullied. That's what we see every day. So it's a reflection of what's going on at home most of the time in terms of in the context of oppositional defiant, in the context of contact disorder. But obviously, if it's to do with a pervasive developmental disorder such as autism, then you cannot really blame the family much there. But then again, you have to see that if the families have issues at home, right, it could exaggerate someone's behavior
or
with
if one
autism.
of the parents is in denial or not prepared to work cohesively.
And it could inflame someone's behavior as well, in terms of a child behaving aggressively or agitated or self-harming, etc.
Some of the comments that we've had also include that we need more public attention, as you said, but also facilities to help. How lacking is Cyprus in this regard?
In regards to what exactly?
Facilities.
Facilities for
mental health.
Yeah, as we have
without the stigma. Without the stigma of saying that I don't feel so good.
As we have discussed in previous occasions, even in the public health sector and the private sector, psychiatrists are quite small in number in the public health sector, and they tend to see a lot of patients. So it's very difficult for them to kind of manage cases when, for example, as a consultant psychiatrist in London, I will see 6 patients in a day in the NHS clinic, because I had to do other stuff as
Yes.
well, like supervising, let's say, the trainees or research or audits, where in Cyprus you see more than 25 patients within the same
goodness.
time. I'm referring to the public health sector.
Right.
So obviously you don't have enough time to
No.
acknowledge someone's difficulties in detail.
Why, all right, well, maybe that's a whole other spectrum that we need to discuss, and we need to have the head of the Minister of Health to
Things
answer.
are changing now. You might need to have the head of YASI, I don't know.
Ask those questions. And Natalie Christopher has asked about the effects of sport on mental health, and how we could, she'd love to see how we can encourage people to become more active.
So as we
Great
all
point,
know,
actually, from Dr. Christopher, because getting the children out of their mobile phones and their social media, I believe, is very detrimental to their mental health and self-image.
So exercise is great, and it's great not just if you have a mental disorder and to prevent a mental disorder, let's
Yes.
say. So we can see that sometimes in mild forms of depression, for example, can be of a great help and support using exercise. When we do exercise, we have endorphins being secreted, some hormones that we produce, and they make us actually feel better, and they boost our immune system and our mental health. So great. I would say that exercise is very important, not just for mental health but for physical health, and it can be a supportive measure for someone who is suffering or for someone who is not suffering from a mental disorder.
Does it matter if the sport is done alone, or do you find that it's has a better effect if they work on team sports? I'm thinking
Of course,
the basketball rather than doing laps
definitely.
up and down swimming, for example.
Definitely, I think it's very important to think about using a sport that you can do with many people together as a group, because that helps with your social interactions, your
Yes.
interpersonal skills. I was saying an example yesterday when I had a patient who plays pool, and he was asking for getting a pool in his house, and his mom was quite against that, and I agreed in a way with her, because if she gets him a pool table in the house, then he will never go out to
Yes.
play pool and meet new people.
Mm.
He'll be very isolated in a way.
Yes.
So it's not just exercise, it's how and where you do your exercise.
It's always a pleasure to have you on the program. Thank you so much. So many issues to speak about. I look forward to welcoming you to
Thank you,
discuss something
Saskia,
else.
for
Thank
having
you.
me today.
Thank you. Dr. George Mikellides, and if you'd like to speak to him or contact him, please do feel free to call me directly and I'll put you in touch. So it's 28 minutes to 2 and you're tuned into a Rick Classic 88.2. We're going to listen to what are we going to listen to? The Haydn Piano Concerto in D major. Thank you so much for watching. Have a great weekend.